So welcome to IGRA for Nurses, sponsored by the Southeastern National TB Center and the National TB Controllers Association. The event will begin momentarily, and welcome. This event is designed for public health nurses. This webinar will provide knowledge about the IGRA blood tests and how they are used to identify patients with past or recent infections with Mycobacterium tuberculosis organism. This knowledge will allow nurses to identify which indeterminate or borderline test results require follow-up. The agenda for today will have presenters provide a brief description of IGRAs, discuss case presentations, facilitate a Q&A, and finally, NTNC will provide some announcements. Today's first presenters are Maria Lasley and Dr. Connie Haley. Maria Lasley is a registered nurse consultant and education training specialist for the Southeastern Tuberculosis Center. Maria has worked extensively with TB since 2008. Connie Haley is an infectious disease physician trained at Vanderbilt University. She has worked in TB since 2001 and currently works as a medical consultant for the SNTC. Additionally, today's panelists are Jenna Hext, Amy Painter, and Kate Lowther. Jenna Hext, is a public health nurse consultant manager for the Tennessee Health Department. She has focused her work on TB and has done so for 6 years. Amy Painter has worked in public health for 23 years in a variety of nursing roles, with the last 14 years spent in tuberculosis control activities. She is currently providing state oversight as the TB controller, and she is the TB division director for the South Carolina Department of Health and Environmental Control. Kate Lowther is a public health supervisor at Public Health Madison in Dane County in Madison, Wisconsin. She has worked with TB for the last 13 years and is the program manager for the tuberculosis and immunization programs, and has her certification in infection control. Now I will turn it over to Maria and Dr. Haley.
Hi. Am I sharing, Donna?
I do not.
Can you see?
No. Yes, you are.
How about that? Okay. Yay. Hello, everybody. It's Maria. You guys all know me. I love to see these numbers. Wow. That's just so happy. I'm very happy to see that. We're going to just hop right in, and we're going to talk about determining if someone is infected with MTB. So we've got a poll. So we want you guys to give your feedback. When I have a patient with a positive IGRA result, what should I do first? If you guys don't mind answering that.
Do you want to read the question? The
people are answering it.
okay. Sometimes people come in from their cars and don't know what the choice is.
Well, I see what you're saying. Okay, yeah. The answers: evaluate your patients. Let me get my little box out of the way. Evaluate the patient's risk for TB exposure. Evaluate patient's risk of progression for latent tuberculosis infection to TB disease. Look at the IGRA quantitative results. Call the TB clinician about the positive result. Refer the patient to get a chest X-ray.
We have, 75% have answered this. People are jumping in there and giving us answers. Are you able to see, Maria? We've got a.
No, I can't see the results, but that's okay.
So that's fine. There we go. Oh.
There we go.
Yeah, okay. I can't see the results either.
There we go. We're sharing them now. You can see them, I hope.
Okay. Well, I know it. Okay, so looks like it's a kind of a tie between look at the IGRA quantitative values versus refer them for a chest X-ray. So we're going to talk about that here in just a few seconds. What we really want to do first, second, and third. All right, so the poll is closed. So guess what? The first thing that we want to do is we want to evaluate the patient's risk for TB exposure. That is the most important thing. You have to figure out if they've been exposed and then where you go next. What type of risk do they have? So every state should have some type of risk assessment to evaluate that. And if you don't, we have several examples. The second thing is to evaluate the patient's risk of progression to latent TB infection to TB disease. And then the third thing is to look at the IGRA quantitative value results. You will do down the road, call the TB clinician about the result, and you will refer the patient for an x-ray if it's necessary regarding the result. But the first three things, or the first three bullets, are actually what you want to accomplish. So when screening for the process, I love this poster, and I always have it as part of my presentation. You want to think TB. During any risk assessment for LTBI, we always need to think TB. TB screening is defined as the process to include the risk assessment, your symptom evaluation. Are they having signs and symptoms? Are they coughing? Are they having fever? Are they chills, night sweats?
Hit that animate one more time.
Oh, that
There
might
you
pop up. There we go. There we go. Thank you. You want to include all of these things: the TB risk assessment, your symptom evaluation, the test for TB infection, the TST or the IGRA, which we're talking about today. You want to talk about the additional workup for TB disease as indicated, and then move to the chest X-ray and possibly sputums to see what else would be going on with the patient. But as we were discussing, the TB risk assessment and the evaluation and getting the test are the most important. So how do I distinguish between TB infection from TB disease? For both LTBI and TB, MTB is in the body, and the TST and the IGRA are always, are usually positive. This is super important to remember. Latent TB should not have signs and symptoms. So if someone's coming in and you're evaluating them and they're telling you, gosh, I do have a cough now that you asked, and I have lost a few pounds, but not intentionally, and I have been running a fever and I do have night sweats, well, they probably don't have LTBI at that point. But if they don't have symptoms, hopefully you've not moved them to a chest X-ray, but if you have, because of their positive IGRA and their chest X-ray is okay, then that's a good thing. And then if you did have sputums, you don't want the smears to be positive, and you definitely don't want the PCR to be positive, and you don't want them to be infectious. The other important thing to remember here is extrapulmonary. You can't forget those folks who might have a nodule somewhere, who might have a swollen lymph node, because that's a form of TB, but it's not in the lungs. And I love this slide. We always talk about it. And this gives you a good idea of latent TB infection versus TB disease. You have a few TB germs here, and then you have a whole bunch over here if they did progress to TB. It's hard to tell if someone has progressed to disease unless you have them evaluated, and the clinician determines with the diagnostic results, that they do have tuberculosis. So how do we test for TB infection? We have the TST, which has been around for over 100 years. And then we have our IGRAs, which is our Interferon TB Gold Plus and our T-Spot. How do the IGRAs work? IGRAs are an indirect test to diagnose TB infection. They don't detect MTB itself. Rather, the IGRAs detect the immune response. And it's really important that everyone understands that. It's specific for the antigens that are your ESAT6 and your CFP10. IGRAs are based on the T cell function. So that test doesn't work as well with a patient who has weak T cell based immunity. So if you've got someone that's got T cell functions that have HIV or they're malnutrition, the tests are not going to work as well as if it would be somebody that's a little on the more healthier side. Both IGRAs, the T-Spot and the Interferon, measure the interferon gamma release assay to the blood cells, to the T cells that become sensitized. The other thing I always say is that they get turned on. when they encounter specific TB antigens. And here's an example of what these look like. The QuantiFERON, you can see the tubes here where they collected their tubes and they spun them down, and we're getting tested. We're looking at the amount of the interferon in the T cells. And the T spot, you'll see it over here. It's measuring the number of the T cells that are producing the interferon. So here you've got your negatives, and down here for your controls are your positives. And how somebody counts all those spots, sometimes it's pretty interesting how they're able to do that. This slide just represents the TST. And so you have your memory cell. So we give the PPD. And if the body says, oh, hey, I recognize that, you're going to measure that size, for and duration. And there's cutoffs for those to read the TST. So with the IGRAs, same thing. We're going to draw the blood, and then it measures it, as you can see here. So we're looking for the TNF, the IFN, and then the TNF, if I can say those correctly, guys. When the sensitized memory cells see the MTB again, the immune response can be measured through the IGRAs as the blood test for your local reaction that's measured. You know, the TST is going to be your local reaction. The blood's going to measure, you're going to be measuring the blood. So it's pretty neat that we have a blood test that measures that. So if you guys have collected the QuantiFERON, here are your tubes, and each tube represents a function. So you have your mitogen, which is your positive control, and it's a low response, and it may indicate the inability to produce the interferon. The nilute is your negative control, and it adjusts for the background for your interferon. Your TB1 is your primary tube, and it's going to detect the CD4 T cell response. So that's your TB1. You're going to hear us always refer to that as your TB1 tube or your TB1 antigen tube. Your TB2, it's going to optimize, and it's going to look for the tip detection of your CD4 and your CD8, and it's more sensitive. And you'll hear us refer to this as your TB2 or your TB2 antigen tube. And so here, some folks will say, oh, look at your TB1 or look at your TB2. Well, here's what's important to remember, and a lot of folks kind of forget this sometimes. Either with your TB1 or your TB2, if either one of those are positive, your test is positive. But again, we'll talk about that in a little bit. You have to evaluate the risk of the patient, and you have to consider the environment of why that patient came to you for the test. So with your T-spot, the interpretation of the results here, and I love how this is represented. You have your negative control at the top, and then you have your positive, your ESAT6 for your panel A. Then you have your CFP10 for your panel B. So your positive control is going to be your 8 spots. Your negative is going to be less than 4. And this test has a borderline. So, you know, a lot of folks ask, you know, in between the QFT and the T-spot, does it have a borderline? And it does not. But your borderline is 5, 6, or 7 spots. And then you have your invalid. The inclusion of the borderline category is intended to reduce the likelihood of false positives or false negatives that are around the test cutoff. Note, it's recommended that the borderline and the invalid should be retested on a new sample. And so anytime someone asks, and Dr. Haley gets asked that a lot in emails and questions, well, I got this result, what should I do? You have to repeat it. And you know, when you choose to repeat it, if they need it right away, then you need to repeat it right away. Remember, a negative TST or IGRA does not exclude LTBI or TB disease. You must interpret the test results in the context of the patient's risk, their setting, and the patient and the source case factors. So it's super important that you get all that information when you're collecting your risk assessment to find out why they're there. Why do they need that test? Who sent them there? Is it a contact investigation, or do they need it for their work or their job? So which test performs better? Both the IGRAs are more specific than the TST. And I want to say to you, when you ask one of us, which test do we prefer, we're never going to give you an answer. Oh, you should do the T-spot, or oh, you should do the QuantiFERON. We're just going to tell you to get an IGRA. It's less likely to have a false positive result, and they don't cross-react with the BCG vaccine. And most importantly, it's not affected by an NTM. An NTM, for those of you who probably know, could be your avium or your gordona, your fortuitum, etc. The differences between the QuantiFERON Plus and the T-spot, it's not clinically relevant. You can use either test. It's whatever you have available in your area. CDC some time ago had grants and assisted you guys to get your QuantiFERONs in some of your labs. And, you know, it's been some time ago. And then others have done T-spot. So it's whatever your state program offers or whatever your facility offers where you work at. Accessibility is probably going to be the thing for you guys. Sensitivity is high with all three tests, the TST, the T-spot, and the QuantiFERON Plus. The ability to detect the MTB distinguished by the HIV, immune suppression in young children, and your weak T cell function. So if you're looking in general at the high rate of your indeterminate or your invalid on your IGRAs and your false negative results for all three of your tests, consider dual testing for more immune compromised children under 5. So the advantages and the disadvantages, of course, it's a single visit. It does require phlebotomy. Most of us kind of know how to draw blood, and if we don't, we have to find someone that can do that or send them someplace that can have their blood drawn. You get the results in 24 hours. The disadvantage is the specimen collection and the handling. You have to make sure you get enough in the tubes. You have to make sure that you keep them at the appropriate incubated temperature, and you need to make sure they get where they need to be. You have quantitative and qualitative values that are not subjective. So it's not about placement or reader skill, whereas the TST, that's kind of in the eye of the beholder, as I say, and you're going to read those. And then technical complexities of the test. We're going to talk about that. So by the time we're done with this, you guys are going to feel super comfortable when you're looking at these IGRA results. And that's our goal here. There's no boosting with the QuantiFERON or the T-spot. The disadvantage, it can be a little complicated with the test interpretation. As I said, we're going to talk about that, and you guys should feel really good about this toward the end. It eliminates the false positive due to the BCG, and it eliminates the false positive due to your NTMs. Now, the inconsistency and the reproducibility for serial testing. We don't do a lot of the serial testing like we used to do in the healthcare workers since the guidelines had changed. Your QuantiFERON mitogen values can indicate immune function, and we're going to talk about that in some great detail here soon. The disadvantages, like the TST and the IGRA, they can be affected with your immune response, HIV, and other conditions or treatment considerations. So what are the clinical limitations of the IGRAs? There's no gold standard. We get asked a lot, you know, what are we supposed to see? What is it exactly are they supposed to tell us? But there's no gold standard on truly who is infected with MTB. The TST and the IGRA indirectly measure the immune response for M. tuberculosis. You cannot identify a patient who's infected with MTB, but already cleared the organism from their body. You cannot distinguish TB disease from LTBI, and you cannot identify who is infected. The infected patient will develop TB disease. It's kind of like the crystal ball. We wished we could see all these things, but we're not able to see that. And if we ever come up with a test like that, that'll be wonderful. So how do I evaluate the IGRA results? And this is where we're going to talk about, you guys may get some pen and paper out, or maybe your calculator, is we're going to talk about these specific results and what they say, do, and how that comes about. So you have your specific results here. How are they reported? So in your qualitative result, you have a positive, a negative, or an indeterminate. And that's based on the interpretation of your 4 quantitative values. So positive, negative, indeterminate. With your T-spot, you'll have your borderline or you'll have your invalid. For your quantitative results, these are your numbers. And we're going to show you some results of where they've already done the math for you, and others where you have to do the math in order to be able to know what the result is. The NEAL represents the non-specific reactivity in the specimen. In other words, it's known as kind of the background noise. The mitogen is your positive control. It indicates if the patient's T cells have normal function, when exposed to a strong antigen stimulus. Your TB1 minus your NEAL, and notice I say TB1 minus your NEAL indicates the INF response to the CD4 T cell specificity stimulated by the TB1 antigen. So it's your TB1, which we talked about previously, minus the NEAL. Now you go to your TB2 minus your NEAL, indicates the IFN response with both your CD4 and your CD8 T cells stimulated by the TB2 antigen. So we have for your qualitative, you have your positive, your negative, indeterminate, borderline, or it's not valid. For your quantitative, you have your NEAL, you have your mitogen, you have your TB1 minus your NEAL, and your TB2 minus your NEAL. I know that's a lot to take in, but we're going to talk about it and we're going to break it all down. So how's it reported? Well, your QFT, your positive is going to be greater than or equal to 0.35. Your negative is going to be less than 0.35. Those numbers become important a little bit later when you're trying to evaluate if a patient is truly positive or is it a false positive. Your indeterminate, and this is the one none of us want to see when we get a report back. We're like, oh gosh, okay, what do? We have to repeat it. Well, look, do we have a low mitogen for one of the controls? Or do we have a high NEAL? And those all mean something. So that's why the test is indeterminate. But either way, you have to repeat the test. Did it fail? Was there inadequate blood volume? Was the tube broken? Was there a delay in incubation? Or was there issues with the temperature? It's hard to say. Once it leaves your facility, it's hard to say what happens to it. So with a T-spot, the positive is greater than 8 spots. Your negative is less than 4 spots. Your borderline is your 5 spots. Your invalid is low mitogen and your high NEAL. Your failed is inadequate blood volume, broken tube, or delayed response, delayed incubation as well. So table for interpretation for the quantiferon, and you guys have this in your handout, okay? And those are your TB1s for your positive, all right? And then your TB1 and 2 for your negatives, and then your indeterminate. So your final report, this is how one looks. So I have a positive for my qualitative, and then I have my numbers for my quantitative. So in this report, for a valid test, the NEAL tube must have a value of less than 8.0. So the TB antigen value reported, you subtract the NEAL value. So here we have our math. Your TB1 minus your NEAL, so you have your 8.46 minus your 0.78, and now you have a 7.68. Your TB2 minus your NEAL is 6.71, and you have 0.78, and that equals your 5.93. I know that's a lot to soak in, but we're going to keep covering it. So another example of a positive. So here we have our positive that says it down here in the red, and then we have our quantitatives, and you have your 0.67, your 0.63. So you have your values here. Your TB1, 0.67 minus 0.03, and your result is 0.64. Your TB2 minus your NEAL is 0.63 minus 0.03. So that gives you a result of 0.6. Again, that's a positive. So just to go back to the other one, just really quickly, another positive. You see how different these reports look, but they all have the same information. You just have to kind of mull through it and make sure you correctly subtract what you need to subtract. So here's a negative. So we have our negative result. We have our quantitative result. Your TB1 and your TB2 values are reported, and you have to subtract the NEAL. So here again, we do the same thing. Your TB1 minus your NEAL is 0.41 minus 0.36, and that gives me 0.05. That's a negative. Same thing. If you wanted to, your antigen 2, it minus your NEAL, 0.60 minus 0.36, and that gives me my 0.24. So that's my negative result. So now we're going to talk about your T-spot, and there is your chart. You guys have this as a handout. We're going to discuss these results. With your T-spot, you have your positive, which is our qualitative result here. And then you have the 6 and the 11 as your quantitative result. So there's no subtraction needed. Your panel A and your panel B spot count is already calculated for your negative control. So here is what a positive would read to you guys. For an example of a negative, we're looking at your qualitative negative result there, your quantitative, which is your 1 and your 1. And then you'll see here your controls say that they passed. So no subtraction needed again. Your panel A and B count are already corrected for your negative control. So T-spot, what's a borderline result? Borderline's 5 to 8. It's equivocal. The clinician may interpret this result in the context of the risk. And this is why it's important for you to get your information during your risk assessment. Test to, do I repeat it? Do I treat or do I not treat? Well, that's going to be up to the clinician. So if you have an immune compromised person, the borderline, they may treat for LTBI if they've ruled TB out. Got to remember that. Healthy adult with no risk, they may dismiss treatment with a borderline result and just monitor them and make sure that you educate about your signs and symptoms of TB. The healthcare worker with no risk with a borderline result, you may want to repeat it. Depends on what the employer says. Again, you can teach them the signs and symptoms and monitor it. An example of a T-spot borderline, no one likes to get these, and you're just like, shoot, when I get it. So there's your qualitative, and then there's your quantitative. So is there a borderline zone for the QFT? We get asked this a lot, and no, there's not. When the value is just above or just below your 0.3 cutoff, you're going to have to look at the situation. You're going to have to decide if they're at risk and if it fits what the result is. So you evaluate the risk. Again, you're going to see this algorithm, evaluate the progression. You're going to look at the quantitative results. Do they correlate with the patient's likelihood of being infected? And does the test need to be repeated? Failure of your controls. These are some of the reasons that you're going to have failure of your control. Low mitogen, you're going to have your immune compromised person with your T cell response. Extremes in age, underlying cancer, HIV, low white blood count, poor nutrition or low albumin, and they're going to be immune suppressed. Technical errors. You never know when they get to the lab, what happens to that, or is it too hot or too cold, or did something get broke? And then your high NIL, your baseline, it's evaluated on the antibodies in your recent infection, could be related to some vaccines. An example of an invalid, it's just going to flat out say, I'm unable to report this test. And again, that makes you have to repeat it. So your indeterminate and your invalid IGRA results cannot be interpreted clinically. What is a determinant? You got to look at the quantitative values. Is the mitogen too low and the weak T cell function, you just can't measure it? Is the NIL too high and there's just too much stuff that interferes with that result? So what do? You have to repeat it. Or the clinician can make a decision at that point, do I treat or not treat, depending on what the risk assessment says. So dual testing, if you do dual testing, if you draw their blood, then you can place the skin test, but you have to make sure that they come back for the read, in your between your 48 and 72 hours. The initial test is negative and the person's risk for progression of TB disease is high. And the increased sensitivity is associated with two tests to contribute to a diagnosis. And this might be someone who, has been infected, or they could be high risk. And, if they've had the BCG and you evaluate, gosh, did I get a weird result? Did something just not work out right? The initial test is positive and the person's unlikely to be infected. Was it a false positive? The initial test is positive and additional evidence is required to encourage compliance for the for preventive therapy. Not everybody's convinced that first positive is a true positive. So when you're doing dual testing, the IGRA should be collected either concurrently or prior to the TB test placement. All right, so now we're going to get to our practice case scenarios.
Miss Maria,
you have something to add, Connie?
I do. It's your partner in crime, Connie Haley here.
Yes, love it.
So we were using the panelist chat. We've gotten so many questions and they pertain really to some of this didactic session. And we thought we might take about 5 minutes and knock out a few of the general questions, if that's okay with you. And then we'll go on and answer the case scenario. But we want to make sure everybody's on the same page as we move to those scenarios. So great. By the way, awesome job. You're doing pretty well for someone who's sitting in the direct path of a hurricane.
Is there a slide you want me to go back to, Dr. Haley?
Let me just read a few of these. I think most of these are fairly basic, but one person wanted to ask again, I think you covered this very well, but what is meant by background interferon gamma? One way that I look at it is like when you have a scale and you want to zero it out before you put something on it that you want to weigh really accurately. So by subtracting the nil, subtracting the background, you're kind of zeroing it out so that you get an accurate reading of how much interferon gamma is actually related to TB infection. And so the nil is really like it's the negative control, but it's also a little of sort of non-specific immune reactivity that we're subtracting out so that you can get a better measurement. Someone else was asking about positive results, and you said this very well. The mitogen is the value that's the positive control, and when it's high, it tells us sort of like a built-in energy test that the patient is likely to have a pretty good ability to detect infection if it's there. And so the immune response should work pretty well if the mitogen is high. If the mitogen is really, really low, that might indicate that a patient's got something else going on. They have a poor immune response function right now. And they may, so if you get a low answer, it may not be as accurate as you want. And so those are questions we get a lot in all of our classes. Let's just see another couple here that I can knock out. One person asked, do other countries use quantiferon blood tests to identify TB infection? And the answer is yes. Not nearly to the extent that we use it in US and in other Western countries, but through our overseas immigration screening programs, the US has actually built the capacity for some labs who are evaluating patients who are moving to the United States to be tested with IGRAs in addition to getting sputum for culture and drug susceptibility testing. So this is a test that's expanding across the world. And I think that, let me just see, sensitivity and specificity, that's one I always struggle with. Related to these tests, when you have a patient that's high risk and maybe doesn't have great immunity, you want a test that's going to work really, really well to pick up TB, even the smallest amount of TB if it's present. And so you want a high sensitivity, the ability to pick up TB if it's present. But you also want something that's specific, meaning that if you determine that it's TB, or if you find a positive test, you want it to really be positive due to TB. And an example of that would be that the skin test is sensitive. It will likely pick up infection if it's there, but it's not very specific because a positive result could be due to a prior BCG vaccine, or it could be due to non-tuberculous mycobacteria here in the US, which is ubiquitous, right? We're all exposed to NTM, especially in the Southeast and some other areas. And so you don't want a test that's that cross-reacts. You want a test that says, this is really TB. And in a low-risk person, like maybe a healthcare worker, you don't want to get false positives because you might overtreat. And so you want a test that says, if this is much more likely, if this is positive, we think it's probably really infection. And that's why the IGRAs are better than the skin test. Do you think, Maria, those explanations helped a little bit?
I hope so. That is a lot of our questions. They're hitting on the ones that we've seen in the past. So I think you covered them very well. This is not an easy topic to understand. And I'll have to tell you, when this was asked, why do we need to have this? It's because there's no literature out there that guides anyone to show you how to look at these. And they just assume that if you read the insert, you're going to understand all of this. And you can't. It has to be explained. There's nuances, just like Dr. Haley was saying, and there's things that affect these tests. And so you have to be, as long as you've done everything on the front end, you've gotten their risk assessment, you understand why they're there. The physician understands, why they're there, and then you see the results and the picture makes sense, then you're good. If the picture doesn't make sense, it's like Dr. Haley said, okay, we have to stop, we have to back up, If we have to redraw and do the result, do the test again, okay. But if it looks, like it is and it makes sense, then we move forward and we let the clinician decide at that point, given the situation, just exactly like she described. They have
Right.
to decide, are they going to move forward with treatment or not?
And one of the reasons we're telling you the limitations of these tests is that these tests, because they aren't measuring TB like a culture, or PCR measures TB and says it's definitely TB, these tests have limitations. And so if you don't have a good immune system, it may affect the ability of the test to work. And if you haven't asked the patient if they have other conditions, if you haven't thought about the fact that they may have active TB disease and therefore they're so sick, their immune system may be distracted trying to deal with that infection, then
Exactly.
it can affect the results. And so the results of the test are only as good as you have to think about the patient who has the results more than the results that the patient has. And that's why this is, to me, more complicated sometimes than some of the stuff we do with active disease. Just a couple of other little things I want to knock out. Someone asked me, do memory cells permanently remember TB? And that it's hard to explain why their skin test or IGRA may stay positive even after they've taken treatment. And so the answer is, in theory, once your body has recognized something, it's got that built-in acquired immunity, and you should have it persisting throughout lifetime. However, things can wane over time. And so if you haven't seen that infection and all of a sudden you see it again, and it's been a long, long time, it may take a bit for your body to recognize it. And it may initially, that first test may be negative, but then if you get tested again, now, you've been exposed again. And so your immune system's been stimulated again, and that memory is going to come back up. And that's why I don't want to get too back into skin tests, because that's not our focus, but it's like why we do a two-step for skin tests. They may have gotten BCG decades ago, but they have forgotten it. And so once they get the skin test, it stimulates and they say, "Ooh, wait, this looks familiar." And then they start generating it. So by the time you get the second skin test, you may then end up having a positive result, but it's not because they have a new infection. It's because between that's why we do the two tests like 3 weeks apart when we're doing two-step. They may say, "Oh yeah, this is a remote infection. It just took a minute to remember." With the IGRAs, remember, we're taking blood out. We're not putting something in like you do a tuberculin in the skin test. And so theoretically, there shouldn't be boosting one IGRA to another. But when a patient gets a skin test and the tuberculin goes in, and then they have an IGRA done shortly thereafter, within weeks, there's been one study that showed there may be a small amount of boosting. And it's unclear, does that boosting mean it's boosting the tuberculin is non-specific, but is it just creating an immune reaction that gets read inaccurately, or is it boosting that you've really had that infection there and are forgotten? It's not clear. I don't want you to worry a lot about boosting with IGRAs and skin tests, because it's not a common occurrence. But the goal is, if you're going to do a skin test and an IGRA, do them both the same day. So you're drawing the blood out before you put the tuberculin under the skin, and you shouldn't have any problem with boosting. Or if you give a skin test and you're going to draw an IGRA, wait about a month. If you can't wait a month, chances are you're still going to get a usable result. But that's where it might be worthwhile to ask the clinician to help you out with whether or not having a skin test a week before might have affected the results. If it's a strong, robust positive, it's usually not relevant. It's usually those results that are really close to the cutoff. That's when we start to get uncertain about what the results means. And so with that, we are going to go to our cases, because I think these cases are going to give some examples that help you understand a few of these nuances we've talked about. And remember that we'll get as much as we can now, and we're going to answer lots of questions after the cases, but we're glad to have additional training on this, because it is complicated, and it's something that comes up a lot in our practice. So thanks for letting me jump in and share some things.
Absolutely.
And Maria, you're doing a great job, and I'm looking forward to hearing from the rest of our nurses as well.
All right, Miss Amy, you're up first. So there is your case scenario.
Thanks, Maria. Super excited to see everybody on here this afternoon. All right, get a pen and paper because we're going to go through some values as we work through these scenarios. And these are real life scenarios. So we have a 46-year-old female who noticed a new right neck submandibular mass 2 weeks ago. No difficulty breathing currently or recent weight changes. Did have complaints of occasional night sweats last summer and lost about 40 pounds about a year ago. Has occasional chronic dry cough that she attributes to smoking pot. Born in the US, was incarcerated from 2017 to 2019, and in prison had a really large tuberculin skin test, but the prison nurse told her it was likely enlarged because she had scratched it. These are the stories we hear quite frequently. We obtained a QFT plus. Maria, next slide.
Got it.
All right, so the results of that came back. We're going to do some calculations here. We've got a TB1 antigen of 2.01, TB2 antigen of 2.71, and remember we want to subtract the nil from each of those values to get a result. We'll give you a second. All right, next. So once we subtract the nil from the TB1 and the TB2, we've got a 1.98 and a 2.68. Next slide, please. So when we look at our grid, we're going to look that these values are greater than 0.35 and have a greater than 25% of the nil value. That's both for the TB1 and the TB2. Maria, can you progress? So in this particular situation, this is a positive result and infection is likely. Next slide, please. All right, now we have a poll question. This patient has a positive QFT plus. Does she have latent TB infection? If you could open the poll. The answers are yes, no, and I don't know yet. Donna, how are we on answers?
We are at a like 68%, 70. We'd like to get just a few more, but I see people are actively answering. They probably need just a moment or two to think about it. They're like, oh, wait, what did she say? So just one more moment. I think we're probably good. I'm going to go ahead and end this poll and share the results.
All right, 75% of you said, I don't know yet. And that's a good answer. So when we think through the scenario, and Maria, we'll pause on holding to the next one. We know that we have somebody that lived in a congregate setting. We know that they've had some TB symptoms, so complaints of weight loss, dry cough. We know that we've got a history of perhaps a positive skin test. Maria, do you want to progress to the next slide?
Sure.
So I do trust that this is a positive result, especially in light of the fact that she had a likely positive tuberculin skin test while she was incarcerated. We do know that she is infected with Mycobacterium tuberculosis, but we don't have enough information yet on whether or not she has latent TB infection. Remember, because latent TB infection is a diagnosis in which you've ruled out active disease, or if she has active disease. So you want to look at that clinical context with that right neck submandibular mass and other symptoms. And you want to do your clinical workup, chest x-ray, perhaps sputums, and assess that mass. All righty.
That is great. Thank you, Amy. All right, we are going to go to case number 2, and this is Jenna.
Okay, so case number 2 is a 68-year-old male born in Pakistan. He has a past medical history of diabetes, COPD, heart disease, and end-stage renal disease. He's been reporting symptoms of cough, 25-pound weight loss, night sweats, and malaise over 3 months. His chest x-ray demonstrated multi-lobar nodular infiltrates in both lungs. He is AFB smear positive and gene expert positive for MTB. So kind of right there, that's already indicating that this person is a case. He has a T-spot that was reported as negative. Maria, next slide, please.
Got it.
So here is our panel where we're looking at the result of the T-spots. We have panel A that has 2 spots. And again, this is already corrected for the negative control. We have panel 3 that has 3 spots, and then kind of just looking down, we have our positive control and negative control, which passed. So when we look at our chart, we are both on panel A and B below less than 4 spots. So that result is going to be negative. So this suggests that infection is not likely. Maria, next slide, please.
Okay.
So here's our poll question for everybody. This patient has a negative T-spot. Do you believe this result? Yes, no, I don't know.
We are getting some quick answers here. We're already at 60% answered this.
It's either getting better
Yeah,
at it.
there's a strong
Yeah.
leaning towards no on this, but yes, they are really starting to answer this. And okay, go ahead.
You want to go ahead and you think we should put up the results or a little more
Share.
time?
Yeah, go ahead.
Okay, all right. So we have 70% that says no, 10% that says yes, and 20% that they're unsure. Okay, let's go to the next slide.
Okay.
So with this particular scenario, based on the number of spots in the panels A and B, this is a negative T-spot result. However, this is a big however. You know that he has MTB in his body because he has a positive gene expert in AFB smears in the context of having a high risk of TB and a clinical presentation that fits with active TB disease. And I'm going to kind of break down that little bullet right there. So having a high risk of TB. So this person is originally from Pakistan, which has a higher incidence of TB. And he has a couple of risk of progression factors. He has diabetes and end-stage renal disease. And then we will look at his clinical presentation. He has symptoms that align perfectly with TB. He has an abnormal chest X-ray that's consistent with TB. And he has AFB smear positive gene expert, so we know it's active disease. The T-spot failed to detect TB infection probably because he was quite ill with this TB disease. So kind of, again, pulling on that with this clinical presentation, he's been reporting symptoms for months. He has bilateral involvement in his chest X-ray and he's smear positive. These are all suggestive of a high burden of disease. So the patient's immune system is potentially just worn out fighting against this chronic infection. And he's not able to mount a detectable immune response. And this is evident by the negative T-spot. And in fact, 10 to 20% of patients with active TB have a false negative IGRA result. So this is where it's important that IGRAs are not meant to diagnose TB disease. A positive result may add information and help provide a better clinical picture. A negative IGRA, though, doesn't rule out TB disease because it could be falsely negative. So in this particular instance, if I had a confirmed case of TB disease and they had a negative T-spot or a negative QFT plus, more than likely we would treat this patient for, a few weeks to months, let them improve clinically, and we would redraw that result. And our experience for the most part is that you'll probably see him eventually turn positive. All right, next slide.
Well done. All right. So now we are going to move to Miss Amy again for the next scenario. Thank you, Jenna. That was a great explanation of that scenario.
Thank you, Maria. All right, we have a 4-year-old female. The 4-year-old was US born, but the parents are foreign born. The child has had no foreign travel, no significant health history, but the grandmother was diagnosed with cavitary smear positive TB disease. This child spent many nights in the grandmother's house in the past month. The child is asymptomatic and the chest X-ray is normal. Next slide. When we do the first QFT, we've got a TB1 of 0.12 and a TB2 of 0.14. Next slide.
Okay.
These are already negative, so you don't have to subtract the nil in this scenario. Next slide. Go ahead and progress again. So in this particular situation, thank you, Maria, both of these values are less than 0.35. And so this does give us a negative result. Next slide. So remember, this is a QFT result that is negative. This is a recently identified contact. We've tested this contact 1 week after the exposure ended. Next slide, please.
Now we're going to have a poll, Amy.
Okay, we're going to open the poll up. This patient has a negative QFT plus 1 week after exposure to cavitary smear positive TB. Do you believe this result? The answers are yes, no, and I don't know yet.
These answers are getting familiar.
They're doing great. I'm so
Yeah,
glad.
yeah, you know,
learning.
it's not as clear cut of an answer this time. Not gonna,
Uh-oh.
we've got about 60% response, so we're gonna let this go just a little bit longer, but it's about almost evenly split between yes and I don't know, and just a few less in the no category. So I think we might have a few things to learn here. So let's go ahead and I'm gonna end that poll because we've gotten some great answers here. And I will share those results with you now.
So it
Look
is
at that.
right, almost an even split. 37% of you answered yes, that you do believe the result. 38% said, I don't know. So this is kind of a trick question. So I'm going to go ahead and progress to the next, and you'll kind of see as we work through this, what we're looking at. We repeated that QFT result. You've got a TB1 of 0.6, a TB2 of 1.2. You want to subtract your nil from those. I'm going to pause real quick and let you do some quick math. Okay, progress again.
Okay.
All right. So we know that we have a result, especially that TB2 that is greater than 0.35. That gives us a positive result. Next slide, please.
All right.
And so this actually was a repeat QFT 10 weeks after exposure ended. Remember, it takes time for that immune system to develop that memory for TB. And remember, this is a small child too. So that first test was negative. We repeated that test again 10 weeks after exposure, and we got a positive result. Next slide, please, Maria.
Ready.
And those are your calculations right there. Next. So remember that both IGRAs and the tuberculin skin test measure that T cell memory response, and it can take weeks for those to be measurable. It's why we sometimes do, two-step tuberculin skin test. It's why we want to make sure during a contact investigation, we want to do that test when we identify the contact, but we want to test again 8 to 10 weeks after exposure. For young children who are contacts, we want to look at that clinical picture. We want to make sure that we rule out active disease, even if that test is negative, because remember, a TB or an IGRA or a tuberculin skin test is only part of that clinical picture. You want to do that chest x-ray, and adults generally don't need a chest x-ray during a contact investigation unless either of the tests are positive or they have symptoms. You might want to consider a chest x-ray for somebody who is immunocompromised. And then, of course, children less than 5 should start on window prophylaxis if that initial test is negative, until we can repeat that second test at that 8 to 10 week window.
Great job, Amy. Thank you so much. That was that gives us an example of conversion. All right, Kate, we have case scenario number 4.
Great. My name is Kate Luther, again, from Public Health Medicine in Dane County. So this is case scenario 4. This involves a 22-year-old female who was tested for work. She actually works at a local childcare facility as a childcare assistant. And in this situation, she has no TB risk factors. She was born and raised in Wisconsin, so in the Midwest. She doesn't report any recent travel, and she's not had any TB exposures in her lifetime. And she doesn't have any active signs of TB disease, no cough, fever, night sweats, your typical symptoms that you see with TB disease, and no underlying health condition that would predispose her or put her at risk for progression to TB. And the only reason that she's seeking care through her primary care provider is for a burn that she has. So for employment, her clinic placed the TB skin test in June of 2022, and they recorded it as 15 millimeters. And so a couple weeks later, they do a chest x-ray and they report it being normal. And then a couple weeks later, they do a quantiferon on this individual, and they report that as being negative as well. Next slide. So when we look at the result of the quantiferon, remember the qualitative was that negative report. But when we look at the actual numbers, those quantitative values, the TB1 minus nil was 0. The TB2 minus nil was 0. Her mitogen was greater than 10, again, that she can mount an immune response, right? That's what the mitogen is. And the nil was 0.06. You can advance to the next. So again, the TB1 antigen and the TB2 antigen are both negative, so you don't have to subtract that nil. Next. And so on the grid here, we see that, again, it's the cutoff is that less than 0.35. So that is the negative result, which means M. tuberculosis infection is not likely. Next slide.
Okay.
All right, so this person is low risk. Again, you look at that big clinical picture, the person is from the Midwest, no travel, no symptoms. So again, has low risk and has a negative IGRA after a positive TB skin test. Next slide.
We're going to do a poll.
Yep, we're going to do a poll. So the question is, this patient has a positive TB skin test and a negative quantiferon. Which test result do you believe? Is it the TST or the TB skin test, the quantiferon results, or neither? You need to get a T-spot for a tiebreaker. So we'll give you a moment to log your vote.
Moving quickly here. We have a really strong answer of the QFT results. Almost, that's a real high 88%. And then the rest are either the TST or neither. So
Yay.
give this just another, I think we've got a pretty strong answer here. So let's go ahead and end that. And I'm sharing the results.
Great. Yeah, so 87% of y'all think that it's the quantiferon results that we believe, and that's right. We want to go with that response. And if you go to the next slide, we'll kind of take some of that and break it down. So again, this is a low risk person. So they have no risk for TB exposure, no risk for progression. They had the negative quantiferon, which fits her low risk profile, right? It fits that she doesn't have any signs or symptoms of active disease either. And really, again, like we talked about earlier today, the advantage of the IGRAs over the skin test, again, it's at higher specificity. It's specific to that TB germ. And so they're less likely to have a false positive as a result to BCG vaccine, or maybe those NTMs, those non-tuberculous mycobacterium infection. And in Wisconsin, I can tell you that we do have NTM. And so likely we could see individuals who test positive on a skin test, but then have a negative quantiferon. And again, it's because that specificity of the IGRA. And again, this person has no active symptoms for TB disease. And so in this situation, it was likely that it was a false positive. That TB skin test was likely a false positive. It could have been from an error in the TB skin test placement or reading, or it could be because of that NTM. So that is case number 4.
Thank you, Kate. Okay, we're going to case scenario 5, and this is Miss Amy.
Thank you, Maria. All right, we have an 83-year-old female living in a congregate setting. She was identified as a close contact to a TB case. There's no reported cough, night sweats, fever, or weight loss. And this is the QFT result. So as you can see, the values are the same for the NIL, the TB antigen 1, TB antigen 2, and the mitogen. Next slide, Maria. So how do you interpret these results? So let's do the math. If you've got a TB antigen 1 of 8.63 and you minus the NIL, which is 8.63, you get flat 0. Next slide.
Oh, got to do our poll.
Oh, poll, please.
There
So
we
how do
go.
you interpret these results?
Oh, they are coming in quick.
Yay!
All right. I would, yeah. All right.
They're getting
let's get
smart.
this-
They're getting smart.
Yeah, no, I think they're catching on to y'all.
Yep.
Let's give it just a little bit more time. We're at about 50%. So, and the percentages are changing. It's a real strong in one direction, but others are putting in their opinions. We're at 58%. Let's give this just a little more time. This one I think takes a little bit more time to do some calculating in your head. All right, kind of bottoming out here at 62%. So I'm going to put it in here, but I also would tell you not as many people answered this one. So keep that in mind when you're talking about this.
Okay.
All right, so we have 59% of you answered that this was indeterminate. And that is
Oh.
exactly how that result came out.
Go.
All righty. So the patient had an indeterminate QFT plus result. and we should always repeat an indeterminate result. It's really not clinically useful, but you want to look at why was this result indeterminate. In this particular example, they all have the same value. So is it an error of collection? Is it a lab error? We really don't know. So that's where that repeat QFT would be beneficial. And if the second test is also indeterminate, you might want to consider using a different test. I will tell you for this particular example, when you look at the whole clinical picture, this particular patient had a chest x-ray with moderate opacities in the left lung base. And remember, we identified this particular patient as being a close contact in a contact investigation. So we have a chest x-ray with moderate opacities in the left lung base. The CT shows a new focus of central lobular nodules in the left upper lobe. And in this contact investigation, we have over 50% of close contacts with positive IGRAs. So we ended up treating this person as a clinical case of tuberculosis, but I will tell you that the repeat QFT was positive.
There we go. That answers that. Well, thank you, Amy. All right, we're going to go to case scenario number 6, and this is Miss Jenna.
All right, here we go. Case scenario 6. So here we have a 49-year-old male with HIV on antiretroviral therapy for 2 years. He has a CD4 count of 360 and a viral load that's undetectable. He reports no TB exposure, no foreign travel, and he's from the United States or any other risk factors except drug use. He reports no symptoms of cough, fever, chills, or night sweats, and his chest x-ray was read as normal last month. So he was tested for TB infection to enter a drug rehab program. And here we have his QFT results listed below: the TB antigen 1, 0.36, the TB2, 0.19, the mitogens above 10, it's good value, and a nil of 0.06. All right, Maria, next slide.
All right.
So here we're going to do a poll question. How do you interpret this QFT result? And I'm going to give you a hint. These values are the raw values. The nil was not subtracted. So please do a little math. Take the TB1 and TB2 and subtract that nil value and see what you get.
I give this just a little bit of time. People need to do some math. It's taking 4 seconds for people to get their answers.
Yeah.
They're
Yeah.
trickling in.
Yeah. You guys are going to be experts by the time we get done. Don't y'all think so? I think so.
And we're at 44%, so I'm going to give this just a little bit more time.
This is why we wanted to do this webinar. This information, we had to get everybody on the same page with how to look at these.
Well, we've gotten 55%. I'm going to go ahead and end this poll and share
Okay.
the results.
Okay.
So we have 80% that said negative, 11% that said positive, and 9% that said indeterminate. Okay. So let's go ahead and go to the next slide.
Okay.
All right, and then kind of go through the animation, Maria.
Alrighty.
All right, so here we subtracted the values. So pretty much the TB antigen 2 was already at a very low number. So we kind of focused on the 0.36, and minusing the nil brought us to 0.3. So that brings us below that 0.5 cutoff. And this is a negative result, or infection not likely. This is a high risk person, but they don't have any, they don't report TB exposure, and they're currently on ART, and they have a pretty decent CD4 count. So in this case, this negative value seems to be accurate. Next slide, Maria. So this patient certainly is at high risk for TB due to his HIV status, but he's currently on ART, and this is a good preventative measure. This is keeping him from becoming severely immunocompromised. The IGRAs and TST should work adequately given his immune function. So pretty much this is also evident by his mitogen level, which is above 10. So that's showing that he is able to generate interferon gamma well for these tests. He reports no known exposure to TB. He has no evidence of TB disease. It is likely that he does not have TB infection, and this result is accurate. So you could get a second test if you had any reason not to believe the results, but more tests can also lead to confusion. So again, if you decide to go down that rabbit hole of doing multiple tests, you have to be prepared for discordant results. So in this case, it's really important to look at the whole picture, the whole clinical picture, again, reviewing his risk factors, risk of progression, and then looking at his chest x-ray, his symptoms, imaging, like everything, and making that decision. Just because you're HIV positive, it doesn't mean that you're going to automatically have developed MTB. You have to be exposed to it first. So, all right, so let's move to our next scenario, Ms. Maria.
Yeah, great job. Great job. Thank you.
All right, so this is our last case scenario. We have a 63-year-old female retired from a rural hospital lab. She accepted a new position at another rural hospital lab. So the employment TB screening on hire performed a QFT plus and it was positive. The patient denies TB exposure. She denies symptoms. She has a normal chest x-ray. So she was referred to a doctor for evaluation and treatment, and he offered her 4 months rifampin for LTBI. But the patient never took rifampin. She insisted that this test was likely a false positive. Next slide, Maria.
All right.
Okay, so this is actually her QFT plus result. So here you can see the qualitative result, which is positive. And then going down below, we have the quantitative results. And again, these are the raw values because we see here we have the TB antigen 1, 0.50 and the TB2, 0.06, but there's no nil value subtracted from them. So let's go to the next slide.
Okay.
All right, so this is our poll question. Look at this patient's QFT plus results. Do you agree that it may be a false positive result? Yes, likely false positive. No, I'm not sure.
Not quicker this time.
They don't need us anymore, you guys. We've showed them. Showed them the way.
Well, I don't know. It's not a consistent answer. It's just an easier, it's just a quicker answer. So right now we're just about same for positive or it's yes and no, and just a little less with I'm not sure. So if you have an opinion, please get that in here quickly. We'd love to get it in here.
Yes.
All right.
And be honest, if you're not sure, you're not sure. It's okay. That's what the whole point of this learning.
Oh, I'm going to close this up here in 3, 2, 1. Here are the results.
All right, so it looks almost like an even split. So we have 39% that says it's a false positive, 36% they say no, it's probably an accurate result, and 25% they're unsure. Okay.
Good.
All right, so here again, we're looking at the raw values, the TB1, 2, nil. And Maria, go ahead and go through the animation. Here we go. So we went ahead and subtracted the nil from TB antigen 1, 0.5 minus the 0.08. And that gave us a value of 0.42. And so that's going to bring us up to a positive result according to our table. But this is the kicker here. 0.42 is very close to 0.35. I mean, there's only a few points there. And this is a low positive result in a low risk individual. So in this particular scenario, some clinicians may opt to repeat the test or, to be honest, dismiss that. And maybe they'll offer treatment, maybe they won't. Next slide, Maria.
Okay.
And in this particular case, the patient did opt to have the QFT repeated. So here we have the qualitative value, which is negative, and then kind of looking down through this box, we have our quantitative values of 0 for TB1, 0 for TB2, with our nil at 0.01 and a good mitogen level. So this essentially is a negative result. So a low positive IGRA result in a low risk person may be a false positive. A repeat test or dual testing may be helpful in the situation, especially if you get a result which you're not expecting based on that person's risk factors. So this patient worked in a lab, but there was no information that it was a mycobacterial lab, which obviously if you work in a mycobacterial lab, you're at much greater risk for exposure because you're handling specimens and cultures. And also looking at healthcare workers or healthcare personnel in general, their risk is actually a lot lower in this day and age. So the more that we test low risk personnel, the more false positives that potentially can occur. And based on this, guidelines have changed. So in 2019, the CDC released a new MMWR report that essentially shifted how we're going to test healthcare personnel. And what they did was the testing of healthcare personnel recommended at baseline for hire, so essentially like a two-step or an IGRA when they're first hired, and then only performing a risk assessment done annually unless TB exposure was known at that particular site or facility or other risk factors. So basically, if you're working, say, like in a TB clinic, obviously you're around and being exposed to infectious cases at a higher frequency than the other parts of the population or even other healthcare facilities. So again, those particular type of settings, we're still going to continue to have our annual testing. But in a low risk facility, once you have your baseline testing, you're pretty much only going to have a symptomatic screening or assessment performed annually because there's no indication to perform that. And we actually have here a link below from the CDC to these new guidelines. All right, Maria, next slide.
All righty. So these are our pearls for our TB nurses. These are going to be our takeaways for the whole presentation. I know we have covered a lot, and I am seeing by the question and answer session that you guys have got some questions out there. As I said, I knew this was going to be very popular. So we're going to talk about the basics. And I always say to Dr. Haley, let's just go back to the basics. And guess what? You have to do a thorough risk assessment when you're evaluating the need for the IGRA or the TST. It's just important to get that right out from the beginning and know what situation that you're in. Consider the patient's risk or lack of thereof and considering the result. Use the correct tubes and the amount of blood. Ensure the proper transport of the sample, the temperature. For those folks that are in the hotter areas, we really have to be concerned about the temperature. You want to educate, most importantly, educate those folks about what the next steps are in the evaluation. You want to educate them about the signs and symptoms of TB, especially if the result was kind of right on the borderline of a positive, and respect the what the clinician wants to do. If it's like these scenarios that we provided and they're not going to, they don't need treatment, but we still want to educate them for the symptoms. If they do have that, we want to see them back and be able to evaluate them again. And then we want to stress the importance of the treatment of TB infection that's recommended by the provider, and encourage them to, to take treatment if that's what the provider wants them to do. So we're going to end with a poll question, and I'm hoping we get a really good response because this is going to tell us that we did a good job teaching y'all today. So here we go, Miss Donna. You guys make me proud.
When using IGRAs, do you understand the quantitative values on the report? Yes, yes, but I'd like more training. No, I need more training to feel comfortable, and I will never understand the results. One positive so far, nobody has said that fourth one. So there's hope. We can all get there together.
Yes.
And I'm going to let this one go for a little bit longer because I know we're planning to compare that to their group's initial responses. So it's not a 1-for-1, but just to get an idea of how the group was responding in that initial poll versus the closing poll. So we're going to
I wanted to jump in and say one thing I slightly disagree with. You said respect your clinician's decision. That is so true. But what I know as a TB clinician in public health is that my nurses, I'm only as good as my nurses are.
That's true.
And
That's true.
I think that's why we are teaching you guys, because a lot of TB docs or a lot of clinics have someone come in occasionally and answer questions, and they may not know as much as you do about these tests. And so I feel like I love it when Maria or any other nurses say, hey, Connie, did you think about this? Oh, yeah, you're right. And so, you guys know a lot now to be able to say, this says positive, but look how low this result is, close to the cutoff, and this is a low risk patient. Do you want to repeat this? Or do you think maybe we don't need to treat? You guys don't make treatment decisions, but I do feel like you guys now will know how to review the results, you know how to do the patient's risk probably better than the docs. And so you can spread this up the chain, and we really appreciate that.
We're training. Yes, we figured that.
We are going to close this all up, but just want to show you that, there's a lot of people that would like more training, and please give us some responses in your evaluations where we're going to ask you some questions about that. We and all the other centers are very interested in how we can continue to support you. So please answer those questions in the evaluation so we can make sure we get some more training to you if you want it.
And we're not done. We've
No.
got lots of time for Q&As. And gosh, Maria, you have a lot of Q&As to get to. So
Well, I see that.
You parse some of those out to our panelists.
All right. And I'm looking. Can they see my screen? I wanted to know that. So can they see the questions there?
No, they just see the Q&A.
Okay. I got you. Okay. All
Word
right.
Q&A.
So we have quite a few questions, and can the rest of the panels can see that. If you guys see something and you want to see something that you might want to address, you go right ahead there. A lot of these we have dealt with. There's a lot of indeterminate questions. How long do you wait before you repeat it? You want to get that right away if that physician is waiting on that result, especially if it's an exposure, or you're looking at a conversion for the second round testing in a clinical investigation.
You mean you would want, with an exposure, you would want to repeat it at 8 to 10 weeks?
8 to 10 weeks, yes.
But if it's indeterminate, you could do it right away.
Yeah, thank you, Dr. Haley, exactly. I am just polling through some of these.
I'll take one of them. I see
ahead.
a question that says, is there advantage or disadvantage between the quantiferon and the T-spots in a patient who's received BCG vaccine in the past? And I think that really gets at the core benefit of the IGRAs. Both the QFT and the T-spot. Oh, I'm sorry, I misread that test. I was thinking compared to skin tests. So IGRAs are better than skin test in a patient who's received BCG vaccine because they don't cross-react. But between the quantiferon and the T-spot, there really isn't a difference. Either test is essentially the same. And I saw another question in there that I think I wrote an answer to, but a patient, I just lost my train of thought. I'll come back to it. I totally lost my train of thought.
I saw a few people are asking, like, why isn't the lab doing the math for you?
That's a great question. And Dr. Haley and I have discussed that a lot. Some of you nurses have not been around long enough. Of course, our panel and the folks on our panel, that's why they're here. We've seen the involvement of the quantiferons, and some of you have been with us to see that. And in the beginning, the quantiferon and the T-spot, they did some things. They said, oh, we're going to have this, we're going to have that. This is what we have now. And they present what the lab tests are specifically. And they set it up to where we have to do the math. Their machines probably aren't up to date to do some of these tests. And I'm sure down the road, we've been told that that will happen. But right now, it's not happened. And this is why this is why we're doing this webinar. A lot of folks didn't know that they needed to do that. And I will tell you, Dr. Haley, whenever she gets a question, and she's so kind about it, she's like, would you just send me the report so I can see the report? Because we kind of already know that possibly that result, the nil was not minused from it. And if she is having to give her opinion about that result, she needs to have all the information. So it's the same thing with this situation in our scenarios. Our panel could not have read those scenarios, not knowing all those results. If somebody just told me it was a positive, but yet it was a borderline positive, but they were exposed to an MDR case, you need to evaluate that situation. So it's a great question. And down the road, let's hope that they do. But right now they don't. And that's why we needed to educate you guys about this and to bring that forward. So, when you're moving that result in front of your provider.
We have more than 99 Q&As. We may have to send some of these out in the Q&A, but how about from our panelists? Do any of you guys have something you want to add from some of these questions?
I'll
Um,
go. There's one question here. Is an IGRA that's strongly positive, but everything else, signs, symptoms, chest x-rays negative, would it not be TB? And I think we've talked about this, like you have to look at the clinical
Yes.
picture, right? You can't just take a test result and just use that in isolation, right? You have to look at the bigger picture. There are some situations where providers may say, this is a clinical case. All the test results are negative, but I really think this is TB based on maybe risk factors or exposure. So really, I don't think you can really just look at one test result and say, this person doesn't have TB or this person does have TB. Again, in TB, we have to look at the clinical picture, take a step back and really take everything in. And then ultimately it would be the provider who would make that recommendation or the prescribed treatment if that was the course. But again, I don't think a single test result is going to say somebody doesn't have TB or somebody does have TB. But I open that up to the other panelists too, to see if they have other thoughts.
Totally agree with you. Anybody else want to jump in for a different question?
I'll take one. I see the question of why we redraw a quantiferon or a QFT plus after a negative result in the presence of a positive smear. So we've talked a little bit about NTMs are tuberculous mycobacteria. So positive smear does not necessarily mean a person has active TB. It could be some other type of mycobacterium. So again, looking at that clinical picture and looking if you have everything points to it could be potentially TB disease, redrawing a QFT could provide some additional answers.
Yeah, Amy, and I think I'll add to that. I just want to reiterate that quantiferons and skin tests and T-spots, these tests are there to show you whether or not the patient might have the germ in their body. They do not tell you if it's active disease or latent disease. And so they're really not a great test for patients with TB disease. The only time I find them helpful in TB disease, if it's like a smear negative, culture negative patient, and your doctor is struggling with whether or not, this patient, maybe the patient's low risk but yet has a classic picture of TB, but no confirmation. Sometimes getting an IGRA that says, yes, there's infection present, sometimes that is helpful. It's one more piece of information that can be added with the clinical picture. But again, these are really not meant to be tests for TB disease. They're really meant to identify infection. And then we rule out TB disease, and then we have LTBI and we would treat based on that. So these are really better when we're trying to make a diagnosis of latent infection. Jenna, do you have anyone?
Yeah, actually, I just picked out a question and somebody asked, how many different TB types does the TB or T-spot and IGRA pick up? And I was going to answer in that this test is very specific for M tuberculosis. And that's what makes it so special, and that we can help really determine between, is this person infected with M tuberculosis or from, rule out them being potentially infected from a MOT, which a TST might indicate. So, and if this question is also referring to TB disease types, again, this is an IGRA T-spot. This is just testing for TB infection. It's not used for TB disease. So, Dr. Haley, you have any comments on this one?
Yeah, I agree with you. I think you said MOT, M-O-T-T, and just for those, MOT is mycobacteria other than TB, which is the same thing as NTM or non-tuberculous mycobacteria. So yeah. Who did case 7? Was it you, Jen?
Yeah, it was me. Yes.
Jenna,
So I
Jenna.
see a question here that says for case 7, does the positive TB1 and negative TB2 have meaning? Do you want to take that?
So again, TB1 is looking at the CD4 T cell response, and then TB2 is more optimized not only for CD4 but also CD8. And I've seen a few questions where people are asking, why are the TB1 and TB2 values sometimes so different? You have a very high TB1 versus very high TB2. And that's all because they're specifically, detecting that particular T cell response. So that's why I think you see this variation in responses.
Yeah, and there's some information. I didn't want to get into this because it's a little bit of a nuance. There's some information that perhaps in the quantiferon plus the TB2 tube, measuring the CD8 response, it may be more commonly positive in recent infections or active disease, and maybe more sensitive in patients who have immunosuppression. But that's suggested but not proven And so I think that the bottom line is for TB, for quantiferon, if either TB1 or TB2 are positive, it's positive. But like in the case 7, which was a low risk patient, those values, one of them was positive, technically over the 0.35 mark, but it wasn't much over the 0.35 mark. So that was kind of an indication that only one is positive and is barely positive. This may not be a real positive. And when the test was repeated, indeed, it was negative. And so remember, the T-spot has a borderline zone, and that sort of just basically says this is uncertain, it's borderline. IGRA doesn't have that, but some people feel that there should be one, because when you're really close to that cutoff, if you have a good, strong mitogen and a nil has been subtracted out, that those are, you have to look at the risk. Those may not be real positive. They may wobble. One day you may test them and it's barely over. The next day it may be barely under. So we always look at the risk and the quantitative values, so you can see how close it is to the cut point or how far over the cut point. Kind of like a skin test. The higher the measurement gets, the more comfortable you feel that it's more likely real. And again, some of these are nuances that we're learning how to deal with clinically. Yeah. So any of other panel have other questions they want to jump in on? There are so many. Goodness,
Connie,
you guys
I have to
really
tell you,
engaged.
Connie, I have to kind of jump in here, and it's 2:30. Can you all believe how fast the time has gone? So what did we end up with? Quite a few questions, and we will try to get through some of those. I did see one where they're saying the case 2 and 3 takeaways are not in the handout. So we'll try to make sure that gets to you guys. We have to kind of move forward now. We have our folks who have assisted with the presentation from the National Tuberculosis Nurses Coalition, and Patty Wood has a few items just talk about at this time. So I'm going to introduce Patty. Is she there? There she is.
Hi, how are you? I've landed.
Hi.
Sorry, a little crazy.
That's
before.
okay. Patty's been in motion traveling. So Patty Wood is one of the representatives for the NTNC. So I will turn it over to you. And did you have any slides, Patty, or are you just going to talk?
I didn't have any slides. I don't know if you got a chance to add them to the end, but all I wanted to do is give a plug to you guys, which is great. Thank you. That was a wonderful, wonderful presentation. There we go. I am part of the National Tuberculosis Nurses Coalition. So we just wanted to give out a shout out to that. This is for our nurses. If anybody's interested in a membership, it's a great organization to network. We have a listserv. If you have questions, you can talk to nurses around the entire United States to get your answer. And we also have 8 webinars, this is being one of them. Our COEs, Centers of Excellence, each do one a year. SNTC did this one, and maybe a recommendation for you, since this one was so great, maybe the next one you could do just the questions and answer follow-up to this one. If you record it, maybe they could watch it and do this, just a suggestion. But we will also are going to have one from Heartland next month. It's going to be on mental health. I don't have a date. I'm sorry, it's going to be in November. I think it's October already, but no, it's going to be November. So look for that advertisement and we'll have a save the date going out with that soon. And the NTNC does for a year. So if anybody has suggestions, please let us know at the NTNC site, or you can email me, or just let us know those webinars that you want to see, because I think these education sessions are so important. But I just want to say thank you, and let me get my advertisement out. And Maria and
Absolutely. Okay.
Everyone, excellent job. Excellent job.
Thank you. All right, I'm going to turn it over to Donna.
Yeah, if you'll go on to the next screen, please.
Will do. Okay.
All right, well, those are some resources. Keep going through those.
Okay.
Right, and okay. So just as a reminder, thank you for joining today's webinar. A reminder that the evaluations are due in by close of business. That'll be 5 p.m. on October 11th. As a reminder, there's a recording of this webinar, and a copy of today's PowerPoint presentation will be available on our website, sntc.medicine.ufl.edu. For a short time, you should be able to access that directly from our homepage up in the banner. Don't forget to check the email that you used for registration to get your evaluation link for this webinar. And if several people joined you today to watch it, please make sure you forward that to those people who watched and did not attend on with their names on the Zoom. Your evaluation is critical in helping us provide valuable feedback to our speakers. It is also allows us to continue to provide these opportunities to you free of cost. And if you have, and please go to the next.
Okay.
And keep going.
Okay.
There you go. If you have any further questions, please don't hesitate to reach out to us, but also reach out to your region's Center of Excellence. If you're not sure who that is, here's a map showing you who your region's COE is. And if you don't have that contact information on speed dial already, please go to the CDC website and they have contact information for each of these centers. So all of our centers are happy to support you, but please, if possible, reach out to your region first. And with that, it's a thank you. And I don't think we have any other screens. I think we can say, let's see, is there one more
Yeah.
screen? All right,
Nope.
there we
There
go.
we go.
So thank you for joining us and have a great rest of the day. Those that are in the Southeast, please stay safe.
Thank you. Goodbye,
Bye.
everybody.
Bye, everybody.